All right, welcome everyone to the third day of our Liberia breast cancer training series. So today we are going to be reviewing nursing considerations for cancer care. So I'm going to pass it off to Alyson Bierling, our program oncology nurse at the Dana-Farber Center for Global Cancer Medicine. And again, if you have any questions during the lecture, feel free to either raise your hand or you can type the questions in the chat. I will be monitoring the chat throughout the entire lecture. All right. We also ask that if you're not speaking or you don't have a question, please mute your microphone. I have the ability to mute people, so if there's any disruptions, just note that you might be muted. All right, without further ado, I'll pass it off to Alyson.
Thanks, Erin. Good afternoon, everybody. Thanks for joining us. I'm just going to pull up my slides here. Just a second. All right, so you can probably see. Oops. Let me see. All right. Do you guys see it in presenter mode? Probably.
Yeah.
Yeah. Okay. Give me just a second. Let me. Oops.
Perfect.
All right. So just the slide now. Great. All right. So I'm happy to be talking to you guys today about nursing considerations for chemotherapy preparation and administration. And while this lecture is titled Nursing Considerations, I think that a lot of this content provides some really important foundational concepts for anyone on the multidisciplinary team who will be involved in providing care to oncology patients. So I hope that this content is helpful and relevant for all of you. And as Erin mentioned, please feel free at any point if anything is unclear or if you have any questions, maybe raise your hand and ask that question. If you have not been involved in administering chemotherapy before, a lot of these concepts are probably pretty new. So please feel free to speak up if anything is unclear. And I think we have the 3 hours allotted just to this lecture, so I won't be using up the 3 hours. We have lots of time for discussion and questions. All right. So this lecture is going to be given in 3 parts. So first, we're going to discuss chemotherapy preparation and administration, all of the steps and safety considerations involved with that. Secondly, we're going to discuss safe handling of chemotherapy. And then finally, we will talk a bit about patient education. So we'll get started first by discussing chemotherapy preparation and administration. So we hope that by the end of this lecture, this section of the lecture, that all of you will understand the nursing responsibilities associated with chemotherapy treatment plan, preparation, and administration. So in the upcoming slides, we're going to talk a lot about various precautions and safety checks that are required during chemotherapy preparation and administration. And a lot of these checks and precautions are not required when you are administering, say, an antibiotic like ceftriaxone. The major reason for this is that chemotherapy has a narrow therapeutic index, which is the range of doses that is effective for treating a condition with minimal adverse effects. What that means is that there's a small window between a therapeutic and a toxic dose with chemotherapy agents. So going back to the example of antibiotics, the therapeutic index of a drug like ceftriaxone would be a lot wider than a chemotherapy drug like cyclophosphamide. So we know that if we give too much cyclophosphamide to a patient, that they're going to suffer from significant toxicity, side effects, even death. But if you give too little cyclophosphamide, if the patient doesn't receive enough, then we're not going to kill the cancer cells that we're trying to get rid of. So it's really important that we are doing all of these precautions and safety checks that we're going to discuss to ensure that patients are receiving the correct dose. So these are the broad categories of steps within the chemotherapy preparation and administration process that we'll now review. And there's some overlap to some of these categories, but you would start by verifying the treatment plan before moving on to mixing chemotherapy. And then next you would complete your patient assessment and preparation of the patient. And then finally, you would move on to chemotherapy administration. And throughout those 4 steps that I just mentioned on the previous slide, there are 4 different instances where an independent double check should happen. This is one precaution that ensures that patients are receiving the correct treatment, the correct drugs, the correct doses at the correct time. Each of these steps involve 2 staff members, usually nurses, pharmacists, separately checking targeted components of the treatment plan. So as the lecture moves on and we get to the points where these checks are required, I'll go over them in more detail. But just to kind of frame this discussion, the 4 points where double checks will happen. The first check will happen when the order is received from the doctor. The second check will happen when the drug is mixed. The third check will happen after the chemotherapy is mixed. And then the final independent double check will happen at the point of administration. All right, so we'll start with the first step of the chemo prep and administration process, which is the treatment plan verification. And so this brings us to our first independent double check. So when the order is received by the doctor, when the doctor provides the order to the nurse or to pharmacy in some contexts, there is going to be an independent double check that verifies all of the following components that you can see on the slide here. So we're going to be checking the order for the patient identification, the date of the order and the date of administration, the treatment regimen, cycle number and day, medications by their generic name, dose calculations, route and duration of administration, supportive medications and treatments, sequence of drug administration, and allergies. So all of this happens before we mix the chemotherapy. In the next slides, we'll go into a bit more detail on that. So the treatment plan that we use to treat a patient with cancer, which Rami went into detail about last week, it's based on clinical research studies. So patients are enrolled in trials, and then the outcome of those trials and those research studies, they tell us what drugs and at what doses are most effective to treat specific types of cancer. So in order to optimize cure for patients, we really need to be following those treatment plans closely. So we want to be ideally following the correct schedule, interval, and doses, again, in order to give the patient the best chance of cure. So an example which Rami reviewed last week is the ACT regimen for breast cancer. So patients receive doxorubicin and cyclophosphamide at 3-week intervals for 4 cycles. And then after those 4 cycles, then we'll move on to receiving paclitaxel every 3 weeks for another 4 cycles. So ideally, we want to make sure that patients are receiving those correct drugs at the 3-week intervals for the correct number of cycles. Obviously, taking into consideration patient factors, if they have toxicities, we might need to delay or change doses. But this is the goal. So what do nurses have to what are the nursing responsibilities when verifying that the treatment plan is correct? So the nurse needs to verify that the regimen that the doctor ordered is accurate and appropriate for the patient that will be receiving it. So we want to be verifying the drugs, the doses, routes, the day, the interval, diluent volumes, and rate. So to illustrate that, there's an example of an order that a nurse might receive from a doctor for the AP regimen. So a doctor might order doxorubicin, 84 milligrams, undiluted by IV push into a free-flowing IV of normal saline over 3 to 5 minutes. And in addition to the doxorubicin, cyclophosphamide, 840 milligrams and 500 mils of normal saline by IV infusion over 1 hour. So going back to all of the pieces that we need to verify, we want to look at the drugs. So our drugs here are doxorubicin and cyclophosphamide. The doses for doxorubicin, 84 milligrams, and for cyclophosphamide, 840 milligrams. The routes, we can see that both of them are given intravenously. The day, these should be given on the first day of the cycle at 3-week intervals. And then the diluent volume, so this tells the nurse or the pharmacist who is mixing the chemotherapy how to mix that drug. So for doxorubicin, that drug is going to be undiluted. So they just draw up the doxorubicin into a syringe and give it directly by IV push. But then with cyclophosphamide, the drug will be mixed in 500 mils of normal saline. And then it's also important to verify the rate. So the rate of doxorubicin, you can see it's given over 3 to 5 minutes, and then the rate of cyclophosphamide is over 1 hour. So these are all of the components that we want to be considering as nurses when we are doing our treatment verification. And ideally, we'll be verifying these orders against a formal protocol or reference. So I think our team will be providing a breast cancer protocol, which will say, which will outline the regimen that a patient should be receiving. So we want to verify that what the doctor has ordered matches up with what the protocol has outlined for a patient with a certain diagnosis. And then if there are any questions or concerns, if there's any discrepancies between what the doctor ordered and what the formal protocol says, you want to make sure that you address those discrepancies before we move on to mixing the drug and administering the drug. All right, move on to the next slide. So one of the components of this treatment verification is verifying dose calculations. And so we'll provide some examples of dose calculations, and we'll walk through how to do these. But if you find that the calculations you as a nurse come up with don't match with what the doctor has ordered, these are some things we can consider. So maybe there was a change in the patient's weight. Maybe you were using a different formula than the doctor to calculate the chemotherapy doses. Maybe there was an error in calculations during the ordering process. So when the doctor ordered the drugs, or maybe there was an error in calculations while the nurse or the pharmacist were doing the verification process. So let's talk a bit more about types of dosing for chemotherapy. So chemotherapy is dosed in various ways that you can see on the screen here. By far the most frequent way that chemotherapy is dosed is the third bullet point here, is body surface area based dosing. So we'll go through an example of how to do that calculation. But some other ways that chemotherapy are dosed is the first you can see on the slide here is fixed dosing. So every patient, regardless of their weight, might receive the same dose. And then this another type of dosing is weight-based dosing. So a patient receives an amount of drug based on just their weight. And then finally, and a bit more complicated is an area under the area under the curve type of dosing, which is used for a drug called carboplatin, which I don't think you'll be using in your setting anytime soon. So I will not complicate things by going into too much detail about that. So really, we're mostly focused on the body surface area based dosing. And just to note, we want to make sure that we're using the current height, weight, and labs for these for the calculations that we're doing. We don't want to use a height from a month ago or labs from 2 weeks ago. When we're doing these calculations, we want to make sure we're using up to date values. So as I mentioned on the previous slide, most chemotherapy drugs are dosed based on body surface area. So this is the total area of a person's skin expressed in square meters. There's a few different ways to determine the body surface area. One of these ways is by completing a mathematical equation. You can see the mathematical equation here on this slide. So we would take the patient's height, always in centimeters, not in inches. We would take their weight, always in kilograms, not in pounds. You'd multiply those values together, divide by 3,600, and then you would take the square root of that value, and that is going to tell you the patient's body surface area. There are tools on the internet. There's websites you can pull up, or on your phone. There's apps that you can use where you just plug in the patient's height and the patient's weight, and then it tells you the body surface area. If using that method, you just want to make sure that everyone is using the same app or the same link on the internet, so the same equation is used. And then finally, a paper nomogram can be used. That was done historically, but is not best practice anymore. So typically it's either manually calculating using this formula or using a tool on the internet or a phone to do that calculation for you. So let's do a practice question together on calculating body surface area and then subsequently chemotherapy doses. So in our scenario, we have Miss S, who is a 49-year-old woman with breast cancer. Today, she's due to receive her first cycle of doxorubicin and cyclophosphamide. Her height is 172.7 centimeters tall. And then her weight is 76.3 kilograms. And the orders for this patient are for doxorubicin 60 milligrams per meter squared, and then cyclophosphamide 600 milligrams per meter squared. So the first step in determining the chemotherapy doses is to calculate Miss S's body surface area. So we're going to do that using the Mosteller equation from the previous slide. So I'll give you all a couple of minutes to do that first calculation, the body surface area. So I don't know if you guys have, if you have a pen or pencil and paper there, maybe you can write down the 172.7 centimeters for the height, and then 76.3 kilograms for the weight. I'll give you a minute to do that, and then I'll go back to the previous slide so that you can refer to to the equation to do your calculation. All right, so hopefully you all have the height and the weight written down. So let me just move back to the previous slide. So now I want all of you to take maybe 2 or 3 minutes and using this equation here, try to calculate the patient's BSA. All right, so hopefully that's enough time. So we'll move on to the second part of the dose determination, which is calculating the doxorubicin and the cyclophosphamide doses for Miss S. So hopefully we all have the patient's body surface area calculated. And then once we know the patient's body surface area, then we can look at our orders, which are doxorubicin 60 milligrams per meter squared and cyclophosphamide 600 milligrams per meter squared. And so we'll use our body surface area to calculate the dose that our patient should receive if they require 60 milligrams per meter squared of doxorubicin and 600 milligrams per meter squared of cyclophosphamide. So I'll give you another 1 or 2 minutes to do step number 2. All right, so hopefully you all have the answers to those both of those questions now. We'll take up the answers on the next slide. So the first step of our dose determination was to obtain the patient's body surface area. So we should have taken the patient's height and multiplied it by the weight, and then we would have gotten 13,177. And then we would have taken that number and divided it by 3,600, which would have given us 3.66. And then the third and final step would be to take the square root of 3.66. And then you should have gotten the answer of 1.91. And then we always round our BSA to 2 decimal places, to the nearest 2 decimal places. So the patient's BSA would then be 1.91 meters squared. So hopefully we all got that answer. And then the second part of the dose determination was to take our body surface area and then multiply it by the dose ordered. So for doxorubicin, the patient requires 60 milligrams per meter squared. So we would multiply that by 1.91. And then hopefully we all got 114.6, or you could round to 115 milligrams. And then for cyclophosphamide, you would take 600 milligrams per meter squared, multiply again by the BFA, and then we would get 1,146 milligrams for our dose of cyclophosphamide. Does anybody have any questions about these calculations? And sometimes these can take some practice. So these are the only practice questions I have incorporated into the lecture today. But if you would like some more practice questions to be sent to you, I'm happy to send those your way with an answer sheet as well. So maybe if you are interested in having some more practice with these calculations, maybe just type your email in the chat. And then I don't know, Erin, if you could record those emails and then I can send the dose calculations, more practice scenarios to you guys.
Yeah, if for whatever reason you guys aren't able to type your emails into the chat now, feel free to contact your administrator, whoever's facilitating the training on your end, and they can send the emails to me, and I can make sure you all get that.
Thanks, Erin. Before we move on, does anyone have any questions about these calculations? All right, I'm not hearing anything, so hopefully that means you all got the same answers as I did. All right. So the next step in our chemotherapy preparation and administration process is chemotherapy mixing. So coming back to our independent double checks, during the mixing process, the double check should happen at 2 different points. So first, we want to do a double check when the drug is mixed. So we want to check the drug vials, make sure that the integrity of the vial and the drug is okay. Make sure it's not expired. We want to check the concentration of the drug in the vial so that we're drawing at the correct volume. Again, we want to check the diluent type.
Alyson, I think we're losing you.
So those need to be mixed.
Oh. All right, sorry about that, everyone. She's having a little trouble with her Wi-Fi, so I think she's about to rejoin. All right, there she is.
Can you guys hear me again?
We can hear you. You're frozen.
Okay, let me switch to my data. Hi, I think I'm back. Can you guys see me and hear me okay now?
Yep.
Okay, apologies for that. I'm in Rwanda at the moment and my internet connection is not the greatest. Let me pull up the slides again. Where did I cut out, Erin?
You cut out right when you started presenting that slide.
Okay. Um, okay, so, um, okay, let me start from the beginning of this slide again. So as I was saying, during our chemotherapy mixing process, independent double check should happen at 2 different points. So we want to check when the drug is mixed. So before you draw up the drug from the vial, we want to check the drug vial to make sure that the integrity of the vial and the drug inside is okay. Make sure it's not expired. We want to check the concentration of the drug so that we're drawing up the correct volume of drug. We want to check the diluent type and the volume. So some chemotherapy most chemotherapy is mixed in normal saline. Some need to be mixed in, say, dextrose. So we want to make sure that it's mixed in the correct diluent. And then the volume also can be important. So some drugs are mixed in 500 mils of, say, normal saline. Some might need to be mixed in 1,000 mils of say, normal saline. So we want to make sure that all of that is appropriate. The administration fluid type, volume, and then the tubing as well. So that happens at the point when the drug is drawn up. And then after one nurse or pharmacist has mixed the chemotherapy, then another nurse or pharmacist should be comparing the order to the chemotherapy labels. We want to be checking for the drug name, the drug dose, infusion volume, the duration and the rate of administration, the route of administration. Is it IM? Is it intravenous? Expiration dates or times, and then again, the appearance and physical integrity of those drugs. All right, so let's talk a little bit more about chemotherapy mixing. So ideally, chemotherapy mixing, or sometimes we say chemotherapy compounding, should happen in a biosafety cabinet, which you can see on the photo on the slide when available. So I think there were plans in place in Liberia to see if procurement of one of these hoods could happen. So ideally, the mixing would happen in a biosafety cabinet, which protects the nurse or the pharmacist who is doing the mixing. If it's unavailable, we want to make sure the compounding happens in a space with a lot of airflow and where no one else, where there's no patients or other care providers. Appropriate Dr. M2, are you able to mute? Getting some feedback from you.
Dr. M2, do you have a question? All right, I'm just going to mute you if that's all right.
Thanks, Erin. So the nurse or the pharmacist who's doing the mixing should be wearing appropriate PPE, which we'll talk about in the next section of this lecture. A chemotherapy spill kit should be available in case there's any spill, which again, we'll talk about in the next section of the lecture. Sterile technique should be maintained throughout preparation. We want to make sure we're not overfilling syringes to prevent the plunger from separating from the syringe. So we don't want to fill the syringes by more than 75% of what the syringe can handle. We never want to express excess chemotherapy or air into the air, into the space, even when we're using the chemotherapy mixing hood. Instead, if you need to express air or chemotherapy drug, you want to take a sterile gauze pad, place that into a sealable plastic bag, and express the air or the chemotherapy in that manner. And again, when we're mixing, we want to make sure we're using the correct type and volume of diluent. And we will provide some standard operating procedures which outline all of these steps really clearly, and that you guys can refer to. I know it's a lot to just remember after hearing it once, so we'll provide those resources for you. So after you have mixed up the chemotherapy drug, we want to label the syringe or the bag that the chemotherapy has gone into. So it's clear what that drug is and how much of it there is and who it's for. So these are all of the components that should be included on the chemotherapy labels. So the labels should include the patient's name, ideally a second patient identifier, so their maybe hospital ID or birth date, the full generic name of the drug, the dose of the drug administration route, the total volume that's required to administer the drug, the date the medication should be administered, expiration date, sequencing. So if we're giving multiple drugs on the same day, so let's say doxorubicin and cyclophosphamide, for example, doxorubicin should be administered first. So that should be clear on the label as well. And then there should be, I should have put a photo of this on the slide, but we should have a precautionary label or sticker. So something in like red or yellow that says that there's a hazardous drug or chemotherapy in that bag. Eva, I saw your hands clapping or your hand raised. Did you have a question?
Yes, thank you. This is Julius from Liberia. Yeah, so I have a question when it comes to the state kit for low income setting. It is a challenge for some areas, more especially here. So you may not have every item available for the state kit. What would be some of your recommendations when it comes to that? That's the first thing. My second question would be when it comes to the drugs, sometimes it's possible to have a carboplatin when it comes to administration. But most of the exercise is restricted to cyclophosphamide and doxorubicin. Is it possible that we have some method used, more especially when it comes to the use of AUC for calculation of carboplatin? Thank you.
Yeah, okay, yeah, I'll address your first question first. So I'm glad you raised that. So yeah, so these labels, these stickers might not be available in your setting. We can talk to procurement and see if it would be possible to procure these. In other settings, what I've seen happen is sometimes people will just take a sheet of paper, and then on the sheet of paper, they could have a template on the computer that would say that would outline all of these components, and then you could print that sheet of paper, maybe have like 8 or so on one sheet of paper, 8 or so labels that include all of these components, and then you could take those printed labels, even if it's just on paper, and then tape that to the bag or to the syringe. So that's one workaround that I've seen in other settings. But we can follow up on this and see if we're able to procure labels. And if not, we could provide like a template that you could use to be able to print sheets of paper out that are like pre-templated with all of the components that are needed on the label. Does that sound okay? Does that answer that question? Hopefully. You're on mute, Eva. Hopefully that answers that first question. And then the second question was with regards to the AUC dosing for carboplatin. I'm sorry, I didn't completely understand what the question was there. Were you asking for practice or examples with AUC dosing?
Yeah, so for using the AUC, some regimen will contain carboplatin in your regimen. So most of the parties have been doxorubicin and cyclophosphamide. So yeah, asking whether it is possible, maybe we can have some parties when it comes to calculation of the carboplatin or using the AUC.
Sure. Yeah, I can definitely include some more information on that and some examples in the practice scenarios that I send you all by email. But I will say there are no plan. Carboplatin is not really ever or typically used in the treatment of breast cancer. So for the foreseeable future, I don't think you will be using carboplatin in your setting. So I don't think it's something that you need to spend so much time understanding and learning about. But absolutely, like for interest sake, I can send some examples of those along. All right. So this brings us to, yeah, thanks for the great questions. So this brings us to the third step, which is our patient assessment and preparation. So we have verified our treatment plan. Everything looks good. We have mixed our chemotherapy. We have done both of our checks with mixing, and everything looks good. So now we can move on to our patient assessment and preparation. So when we're assessing our patient, we want to know the following components. So we want to know what is our patient's diagnosis by pathology. So a pathology report should be in the patient's chart, which tells us that they do indeed have cancer, and the type of cancer, hopefully their hormone receptor status, are they ER positive or negative, HER2 positive or negative? We want to know the patient's stage and their current cancer status, the goal of therapy. So in your setting, I believe you're mostly or exclusively for now going to be treating curative intent cases. But we want to know that the intent is curative as opposed to palliative. An informed consent should be completed, should always be completed before a patient receives their first cycle of chemotherapy. So that should also be available in the chart. And as nurses, we should check that that is there. We want to understand the patient's health history, whether they have any allergies or other comorbidities. And then we want to know what was their response to the previous treatment. So if they received AC or paclitaxel 3 weeks ago, how did they tolerate that infusion, and how did they feel after going home in the days and the weeks after the chemotherapy? So some more, and then here are some components to our assessment that we should be completing as nurses and other multidisciplinary team members. So we want to complete a psychosocial assessment. We want to understand how the patient is doing, how is their mood, do they need any supports or resources. The physical exam, which should include vital signs, make sure there's no abnormal findings there, and then a current height and weight for the chemotherapy dose calculations. We want to know laboratory results. So is the kidney function and liver function okay? Have the blood counts recovered to the point where it's safe to administer chemotherapy? We talked about performance status over the last couple of weeks. So again, if a patient's performance status is 3 or 4 or 5, we really should not be administering chemo to those patients. We want to assess patients for the symptoms that they're experiencing, and then subsequently If they have any toxicities, we want to understand the severity of those toxicities. We would complete our toxicity grading. And then we want to know, does the patient understand the treatment plan? The patient should be well informed and understanding of the plan for their therapy. So a bit more detail on symptom assessment and toxicity grading, which brings us back to our lecture from 2 weeks ago. So these are all of the things as nurses that we should be including in our symptom assessment. So again, we want to understand the lab results, the current lab results of the patient. Are they experiencing any pain? Do they have any fatigue? Are they having nausea and vomiting? That's really important to understand in order to inform what antiemetic drugs we're going to provide to our patients. Are they having any diarrhea or constipation? How is their appetite? Are they eating and drinking okay? Are they having any shortness of breath? Are they having any numbness or tingling? Again, assessing from peripheral neuropathy, which we talked about over the last couple of weeks. And then are there any signs of infection? So these are all really important components that we want to understand before we administer chemo to our patients. All right, so then after assessing our patients, we'll move on to the next step of preparation. So you need to establish an IV site if they're receiving intravenous chemo, provide pre-medication. So with most chemotherapy regimens, there are specific drugs that need to be given typically between 30 to 60 minutes before the chemotherapy is given. So really common pre-medications are antiemetics to prevent nausea and vomiting from occurring. Other common pre-medications are steroids or histamine antagonists to prevent hypersensitivity. So steroids and histamine antagonists such as promethazine should be given before a patient receives paclitaxel. We know that paclitaxel has a high likelihood of hypersensitivity. So we give those medications as prophylaxis so the patient does not have a reaction. Most chemotherapy regimens require some intravenous fluids prior to administration. Reason for this typically is to prevent kidney toxicities or bladder damage. So this is important with various chemotherapies, but particularly important with cyclophosphamide. One of the side effects of cyclophosphamide is hemorrhagic cystitis, or inflammation, breakdown of the walls of the bladder. So our patients need to be well hydrated in order to prevent that side effect. All right, some equipment and supplies we want to make sure we have on hand. Our infusion equipment, so an IV pole, IV lines, personal protective equipment, a spill kit, in case of a chemotherapy spill, monitoring equipment such as vital signs machine, maybe a stethoscope, and then emergency equipment so that we are prepared in the case of extravasation, which we'll talk more about soon, and hypersensitivity. All right, so moving on to chemotherapy administration. And so this is where we complete our final independent double check. So before we administer chemotherapy to our patient, 2 nurses at the bedside should be taking the drug and the patient chart and the chemotherapy orders to the bedside. And they should verify the patient identification. Ideally using 2 patient identifiers, so maybe name and hospital ID, name and date of birth. And then we want to also verify the rate of administration of the drugs. So chemotherapy can be administered by various routes. So some chemotherapies are administered orally, Some are administered intravenously, and there's various ways they can be given intravenously. And then there's a whole list here of other administration routes, which for the time being will not be used in your setting. So we'll focus on oral and intravenous routes. So what are some nursing implications for oral administration? I just wanted to highlight some oral drugs that are given to treat breast cancer. So those drugs include capecitabine, which is a type of chemotherapy, and then some hormone therapy, letrozole and tamoxifen. So it's really important to be doing good patient education when patients are on oral drugs to help promote adherence. We want to teach the patient to bring the pill bottle back with each office visit so we can make sure that they have completed their entire dose. Patients and their family should be advised to use gloves, ideally at home, when handling all of the drugs to protect themselves from the harmful effects of those drugs. And oral chemotherapy orders should ideally be pre-printed to prevent any errors. Moving on to intravenous administration, some nursing implications for this route. So one really important thing to mention is the PIV site selection. So ideally, an IV that's going to be used for chemotherapy administration would be given in the upper extremity veins in adults, so not in the lower limbs, not in the legs. And then ideally we want to use the most distal, so close to the wrist or to the ankle in pediatrics site possible. We want to make sure we're avoiding sites with poor circulation or injury or lymphedema. And then we also want to avoid areas of flexion. So for example, the antitubutal vein, areas over joints such as the wrist. And the reason for that is we want to prevent dislodgement of the IV catheter. And then we also would not want to select a site where there already was an IV placed in the last 24 hours. And then we try to use the smallest gauge and the shortest length IV possible for the type and rate of therapy. So typically a 22 gauge catheter is pretty good for chemo administration. Definitely would not want to be using an 18 gauge, maybe 20, but typically in adults 22 is pretty good. In terms of PIV maintenance, anytime we are accessing that line, we want to be using aseptic technique. And a new peripheral IV should always be placed on the day of chemotherapy. So if a patient, say, was admitted in the hospital for the previous 4 days and had an IV placed on admission, we want to select a new site for an IV on the day that they're receiving chemotherapy. We don't want to reuse that one from 4 days ago or even 2 days ago. Of course, if the dressing is wet or soiled or not fixed well to the skin, we would want to change that dressing. And then, of course, keeping in mind some complications such as bleeding, nerve injury, infiltration, phlebitis, and thrombosis. I want to spend a bit of time talking about vesicants. So vesicants are drugs that can cause severe damage and necrosis to the skin and other tissues if it leaks outside of the vein. So we know that there are certain chemotherapies that are classified as vesicants. One really common example is doxorubicin. So doxorubicin is a vesicant. So if the doxorubicin is administered or if it leaks outside of the vein, it can cause really severe tissue damage, which you can see a photo of on the slide here. This would not happen with a drug like cyclophosphamide or like an antibiotic typically that you're giving. We know that there are certain chemotherapy drugs with certain and for certain reasons, they can cause that severe tissue damage. So we need to take special precautions, which we'll talk about when we are administering those drugs. And then just to note, paclitaxel is classified as a mild vesicant. We don't take the same precautions as we do when we're administering paclitaxel as we do with doxorubicin. It doesn't typically cause tissue damage if it leaks outside of the vein, but there have been some reports, some cases of that happening. So just need to be careful with that as well. So extravasation is a term that we use to describe infiltration of a vesicant. So if you're administering doxorubicin and the doxorubicin leaks outside of the vein and then is administered into the tissue, that is called extravasation. So what are some signs and symptoms of extravasation? So pain is really typical, usually described as burning, stinging, or a sensation of coolness around the site of administration. It occurs with most cases of extravasation, but it is possible that some patients initially might not have any pain. And then the course of pain typically is that it increases with intensity over time. Redness can occur, swelling as well. Loss of blood return is a telltale sign of extravasation. So if you're administering your vesicant and then there's, you check for blood return and there's no blood that returns from the IV device, that tells us that extravasation has likely occurred. And then ulcerations are a late sign of extravasation. So typically, say you're administering doxorubicin, you note that extravasation has happened. This can initially is going to be intact, but over the next 1 or 2 weeks, if it's not treated, blistering and even sloughing can happen of that site. And this is typically followed by tissue necrosis, which we saw on the last slide. This photo here, you can see that necrosis has occurred. And if it's really severe, the patient might require surgical debridement and skin grafting or flap replacement. So we really want to do everything that we can to prevent extravasation from occurring. So we'll talk about how to do that on the next slide. So we administer vesicant in a really specific way. It's administered by IV push. We never want to, we want to limit the time that the administration happens. So we don't want to hang it in an IV bag and have it dripping over an hour. We want to limit the amount of time that it runs over. And so what you would do is you would take an IV line of normal saline, open the clamp wide, have the clamp wide open, and then inject the syringe with the doxorubicin on the injection port closest to the patient, and then push the drug into the IV line that way. So the normal saline line is running while you're pushing the doxorubicin to help dilute that drug while it's being administered. And so we want to ensure that blood return is present and that the IV is patent before we start the administration. So immediately before you go to push the doxorubicin, you want to pull back on the syringe, make sure that you see good blood return. And we want to make sure that the IV is free flowing, which tells us that likely the IV is patent. And then in addition to checking for blood return at the point of administration, we also should be verifying blood return every 2 to 5 mils to make sure that no dislodgement has happened and that the drug is still being administered into the vein. And then if blood return would stop at any point, or you know any signs of extravasation. So maybe the patient is complaining of pain, or maybe you know some swelling, you would stop it immediately. And then we'll talk about what to do on the next slide if that happens. But if a patient is complaining of burning, pain, you know any swelling, you know there's no blood return, first step is to stop immediately. And then once you finish pushing the doxorubicin, we want to keep that normal saline line running and flush the line clear with at least 50 mils of normal saline. So if extravasation has occurred, we would stop the infusion. We want to maintain IV access. So you would disconnect the normal saline line from the patient's IV, but keep the IV in the vein. We'd notify the doctor. And then the reason we've kept the IV in the vein, or I guess it's not in the vein anymore, it's in the tissue, but the reason we've kept the IV in the patient is that what you would do next is you would aspirate. So you would take another syringe, attach it to the patient's IV, and aspirate what you can from the access. And then after you've aspirated what you can, after you've taken out as much drug as you can from the patient's IV and their tissue, then you would remove that. And then at that point, you would remove the IV cannula. Next, you would apply a cold or warm compress to the patient. You would do that for 15 to 20 minutes, and the patient should do that 4 times a day for the first 1 to 2 days. There's a recommendation for certain drugs, we want to use cold application. For certain drugs, we want to use a warm application. So for the drugs that you'll be administering in your setting, doxorubicin and paclitaxel, use a cold application. We want to keep the extremity elevated. Ideally, you would mark the area with a marker or a pen to monitor the redness, the swelling, and then you would monitor for worsening ulceration. So you might have the patient come back more frequently, like after a few days, to just keep an eye on that ulceration. All right, maybe I'll stop here for questions about extravasation. I know this might be a new concept for some of you. So does anyone have any questions? Can I clarify anything about extravasation before I move on? And this too is something that we can, we have standard operating procedures for the administration and management, the administration of vesicant drugs and the management of extravasation. So we can share that with you so you have clear guidelines that you can refer to when giving these drugs. All right, so doxorubicin we're giving by IV push. All of the other drugs that all of the other IV drugs you're giving in your setting, you're going to be giving as a short-term infusion. So with the short-term infusion, we again want to verify blood return and IV patency before hanging the drug, but you don't need to be checking for blood return after every 2 to 5 mils with these drugs. You would attach secondary tubing to the injection port closest to the patient, ideally using a needleless luer lock connector. And then you would initiate the flow rate according to the provider's order. So one example that we have been using is cyclophosphamide. So cyclophosphamide is administered over an hour, and it's typically mixed in 500 mils. So you would take your volume to be administered, which is 500 mils, take the time you want it infused over, which is an hour, and take the drip factor of the infusion set that you're using and use that to calculate the flow rate. And then once the infusion is complete, we want to check vein patency again and flush the line typically with normal saline. While chemotherapy is being administered, we want to keep an eye out for immediate side effects and complications. So we talked a lot about extravasation. We want to make sure that's not happening, and hypersensitivity as well as another immediate side effect that could occur. And then we also want to talk to our patients about delayed side effects. So side effects like nausea and vomiting or peripheral neuropathy that would happen in the days and weeks after the patient goes home. Let's talk a little bit about hypersensitivity. So really any chemo agent has the potential in theory to cause hypersensitivity, but we know that there are certain chemo drugs that have a higher likelihood of causing hypersensitivity. So in your setting, the two drugs that have higher likelihood to cause hypersensitivity are paclitaxel and trastuzumab. So paclitaxel hypersensitivity, typically we see that happening on the first or second cycle that a patient receives. And then trastuzumab, typically on the first cycle. So if you have noted that hypersensitivity has occurred, maybe the patient develops a fever or chills or a rash or itching, or bronchospasm, hypotension, you are going to stop the infusion immediately and clamp the tubing closest to the patient. You, of course, will stay with the patient, calling your colleagues over to help and get the emergency cart. We'll check the patient's vital signs and assess airway, breathing, circulation. And then you would administer emergency medications as needed. So sometimes steroids are needed, antihistamine blockers, maybe an H1 blocker like promethazine, H2 blocker like cimetidine. And if really severe, if sometimes hypersensitivity can develop into anaphylaxis, you would give epinephrine. And so these are all drugs that we should have on hand in any setting where we're administering chemotherapy. And this too is something we can provide SOPs for. So it's really clear what drugs we should have on hand and what to do in the case of hypersensitivity. And then we would want to observe the patient until symptoms resolve. So after the chemotherapy infusion has completed or chemo administration has completed, we want to document the following components. So type and location of the IV, patient response to treatment. So if extravasation or hypersensitivity or any other complication occurred, we would note that in the patient file. And then ideally, we would also be documenting any patient or family education we provided, and then any post-treatment instructions we gave to our patient. All right, so that brings us to the end of our chemotherapy preparation administration portion of our lectures today. So I will pause here and take any questions. And then maybe we could maybe take a 5-minute break after that before getting into the next topic. But first, if anyone has any questions, please unmute and let me know. All right, it seems like there's no questions. So Erin, if you're okay with this, why don't we take a 5-minute break? So come back at 3, that would bring us to 3:35. And then we'll get started with the next portion of our talk today.
Yeah, that sounds good.
Okay, thanks. enough time for and
All right, is everyone good to start again? Lesotho team, or sorry, Liberia team? Evas, are you guys good to start again?
Yes, we can start.
okay, great. All right. So we will get started on the next section, which is safe handling of chemotherapy. And during the break, there was a great question in the chat, which was, is it safe to give therapy without wearing any protective gear? And so that leads us really well into this next topic. The short answer is no, it's not safe to be giving chemotherapy without talk about what PPE is needed. So the learning objectives of this portion of the lecture today is to understand the risks associated with hazardous drugs, to understand the steps that we should be taking as care providers to reduce exposure to hazardous drugs. And then hopefully by the end, you will be able to verbalize key points for patient and family education regarding safe handling of hazardous drugs and waste at home. All right, so in order to administer where chemotherapy is administered, it's important to understand the risks that are associated with exposure to chemotherapy so that all of us working in those environments can ensure we're taking the necessary measures to protect ourselves. Chemotherapy was first administered mostly in the US in the 1940s. And at that time, the risk associated with environmental or workplace exposures to chemotherapy was not understood, and safe handling measures were not observed initially. But eventually, various studies demonstrated some of the risks of workplace exposure. And so at that point, then safe handling measures were implemented, and that has evolved over time. So some examples of some of the findings from some of these studies that demonstrated the risks of exposure. There was a study done in 1979 that found that nurses who were working with chemotherapy demonstrated mutagenic substances in their urine compared to those nurses who did not work with chemotherapy. So this was kind of the initial inkling that exposure to chemotherapy might have some impact on nurses. Many other studies have shown that nurses exposed to hazardous drugs, such as chemotherapy in the work setting, have actually demonstrated an increased occurrence of cancers. And then other studies have shown that healthcare workers exposed to hazardous drugs in their work setting have demonstrated chromosomal damage. And I want to note that these findings, these studies were done before there was an adoption of safe handling guidelines. So these risks happen when we're not practicing safe handling measures and when we're not wearing proper PPE and taking steps to protect ourselves. So it is possible to prevent these effects. I don't want to scare all of you off from administering chemo, but just want to highlight the importance and why it's important to be observing safe handling measures. So what are some examples of adverse health effects from occupational exposure? There's a whole bunch that you can see on the screen here. So there is evidence of occupational exposure leading to malignancies or cancers in healthcare workers. There are studies that have demonstrated an increased risk of bladder cancer, leukemia, liver cancer, and non-Hodgkin's lymphoma. There are some more immediate effects, such as an allergic reaction, so allergic asthma, irritation of the eyes, some GI side effects as well, such as abdominal pain, diarrhea, nausea and vomiting, dizziness, headaches, dyspnea, some integumentary and mucosal effects as well, such as hair thinning, mouth and nasal sores, and skin irritation or contact dermatitis. And then there's also some reproductive effects as well, such as congenital abnormalities, increased risk of ectopic pregnancy, infertility, learning disabilities, low birth weight, premature delivery, and stillbirth. So these are things that can happen when that potentially could happen when we're not following safe handling guidelines. So just some history of safe handling guidelines. Safe handling guidelines for hazardous drugs such as chemotherapy have been available in the United States since 1986. And even with all of these safe handling guidelines, it hasn't completely solved the problem of occupational exposure to hazardous drugs. And mainly the reason for that is that healthcare workers are not always compliant with recommendations. And all of this is to just say that there is a need for increasing awareness of the need for safe handling of hazardous drugs among healthcare workers, professional organizations, and regulatory bodies. So I want you all to visualize the setting where you'll be working in. So there's various touch points where there's potential for hazardous drug exposure. It's not just when the pharmacist is mixing chemotherapy or when the nurse is administering chemotherapy. There's a lot of potential touch points where exposure could happen. So this diagram illustrates that. So starting off in the receiving department, when a shipment of chemotherapy is received, there's potential for spill or exposure there. Drug compounding or mixing, of course, there's high potential of exposure there. And then the drugs after being compounded flows into the patient treatment area. Again, another touch point for exposure. After mixing and being administered in the patient treatment area, hazardous waste from those drugs that were mixed and administered. So there might be some contaminants in laundry, and then obviously waste collection, and then finally waste disposal. So just some areas in your settings to consider where exposure might be occurring. So protecting healthcare workers from exposure to hazardous drug requires multiple levels of control. And this pyramid demonstrates those controls from most effective to least effective. So starting at the top of the pyramid, one obvious strategy for reducing exposure is elimination. So physically removing the hazard. The next step on the pyramid is substitution. So replacing the hazard, replacing a hazardous drug with a drug that is not hazardous. The third step is engineering controls. So isolating, protecting people from the hazard. Next step is administration controls. So changing the way that people are doing their work. And then finally, on the bottom of the hierarchy is personal protective equipment. So the top two tiers of the pyramid are not really feasible in an oncology setting. We're not able to eliminate the use of hazardous drugs. We're not able to substitute hazardous drugs for a drug that's not hazardous. So the controls that we are left with are the three on the bottom of the pyramid. So engineering controls, administrative controls, and PPE. So some examples of engineering controls are biological safety cabinets, which we talked a little bit about before, otherwise called mixing hood. There are closed system transfer devices that can be attached to IV lines and syringes to create a closed system so that if when the IV line is connected from the IV cannula, there's no risk of spill. Administrative controls include safe handling policies, educating healthcare workers and training healthcare workers, and then finally, and importantly, personal protective equipment such as gloves, gown, eye protection, and respiratory protection as well. So we'll talk more about these controls that are within our reach in our setting in the next slide. So in resource constrained settings, like in the settings where you guys are working, there are some pretty costly engineering solutions, such as chemo hood, biological safety cabinets, even the closed system devices that can be used on IV lines can be prohibitively expensive. So it's really important when those aren't available that we are strictly adhering to other parts of the control hierarchy that are within our means. So some examples of these are identifying dedicated areas for hazardous chemotherapy drug storage and compounding. So maybe having a separate pharmacy or area in the pharmacy for chemotherapy drugs. Making sure that chemotherapy, in the absence of a chemo mixing hood, making sure that chemo is mixed in area separately from other drugs. And then we want to make sure we're restricting personnel access to those areas. And then, of course, meticulous adherence to work practices that minimize aerosol production. And contamination in the workplace. And then finally, paying attention to training and skills assessments. So this slide just shows some examples of policies and procedures that can be implemented in your setting, which will greatly reduce healthcare workers from being exposed to hazardous drugs. So some examples of these measures are requiring all employees that are handling hazardous drugs to wear personal protective equipment. So not making that an optional option for staff, but making it a requirement that's outlined in policies and procedures. In prohibiting eating, drinking, smoking, or storing food in areas where hazardous drugs are used. Requiring training and documentation of training for all employees that will handle hazardous drugs is another component that could be incorporated into policies and procedures. Having written policies that describe how to clean up a hazardous drug if it would spill, having spill kits available, and then also having policies that address surveillance of employees involved in handling hazardous drugs. Right, there's a lot of content on these upcoming slides. They'll just highlight some additional general practices in the workplace that can prevent exposure. So we want to make sure we're cleaning surfaces, surface spills thoroughly, washing hands with soap and water rather than just alcohol after removing gloves is another important measure. Being careful when we remove our PPE to make sure we're not contaminating ourselves. And then placing waste from chemotherapy mixing into a plastic bag before removing it from the hood and disposing it. All right, this is just a continuation of some more general practices that we can observe to prevent exposure. So we'll provide all of these slides with you guys so you can review these in more detail. I won't go through all of these. So let's talk in some more detail about personal protective equipment. So gloves are a really important piece of our PPE. There are specific gloves that have been tested and demonstrated that they protect the worker from chemotherapy. And so there is a list of those types of gloves, and we'll work with procurement to make sure that those gloves are available in your setting when chemotherapy when handling chemotherapy. Double in some settings, double gloves are recommended when you're mixing chemotherapy or administering chemotherapy. So you would put one glove on the inside of the gown, and then put the gown on, and then put another glove on the outside. The gloves should not contain any powder. Of course, we want to inspect gloves before putting them on, making sure there's no holes or issues with the gloves. And we should be wearing gloves when we are mixing or compounding chemotherapy, when we are administering chemotherapy, when we're handling spills, when we're disposing of chemotherapy, and cleaning any areas where chemotherapy, where that might be contaminated with chemotherapy. And another best practice measure with regards to gloves is to change gloves every 30 minutes. So if you're mixing chemotherapy, you might be in the mixing hood for an hour or two. You want to make sure that you're changing gloves every 30 minutes. And then, of course, if the gloves become damaged or contaminated with drug, we would change those gloves immediately. We'll talk a bit about gowns now. So the gowns that we use to protect ourselves from chemotherapy should be disposable. Ideally, we should not be reusing these gowns. These gowns should resist permeation by hazardous drugs, so they should not be a cloth material. They should have some degree of plastic or another material that prevents any permeation. They should close in the back, they shouldn't be open in the front. The gown should have long sleeves with closed cuffs that are elastic or knit. And then they should not have any seams or closures that could allow hazardous drugs to pass through. And then we want to be careful when we're removing our gowns that we're not accidentally contaminating ourselves with something that might be on the gown. How do we protect our eyes and our face from hazardous drugs? So we don't, there's certain situations where we might require eye and face protection. And this would be in situations where there is potential for splashing on the eyes, the mouth, or the nose. And so if that does, so in those situations, we would want to be wearing goggles or a plastic face shield. And then if there is exposure to the eye, we want to be using an eye washing to flush the eyes right away. I'm not sure if an eye wash station is available in your setting. If not, that's okay. Another alternative is to use an IV bag of normal saline connected to an IV tubing and then irrigating the eyes that way. Respiratory protection. So in scenarios where drug aerosols might be present, such as when you're administering aerosolized hazardous drugs, which I don't imagine you'll be doing at this point in time, or when you're cleaning up the chemotherapy spill, respiratory protection is required. And when we need to make sure we're using a surgical N95 respirator in these cases, as surgical masks won't provide the necessary protection from drug exposure. So these should also be on hand in your settings, the N95 masks, and included in a spill kit. Here are some measures that can be taken when mixing chemotherapy drugs to prevent exposure. So again, we've talked about the mixing hood or the biosafety cabinet. We want to, you can see in this, this photo here, the nurses that are mixing chemotherapy, they are wearing gowns. You can't tell, but I believe they're wearing 2 gloves, or they should be wearing 2 gloves. And they are wearing a 95 respirator as well. So that is the PPE that's required when compounding. All right, so, and again, I mentioned this earlier, but we want to make sure that syringes are never more than 3/4 or 75% full to avoid the plunger coming off of the syringe. So then after we've mixed chemotherapy and we've moved on to administration, here are some measures, again, to reduce exposure. So we've talked a bit about a spill kit. So this should be available and used. If there's anything more than a few drops of chemotherapy, that's what we consider a spill, and that is when the spill kit should be used. The PPE that's required when you're administering hazardous drugs is 2 pairs of gloves. We want to wear a mask with face protection if there is a chance of hazardous drugs splashing. And then we want to be wearing a gown as well. We want to perform all work below eye level. So if you're spiking a bag of chemotherapy, you don't want to be doing the spiking above your eye level on an IV pole. You would lower the bag and the IV set, maybe on a table, that you're doing that below eye level. And then after we have administered our chemotherapy, it's important that we wash hands with soap and water, not just alcohol. That friction and then the rinsing is helpful in removing hazardous drug contamination from your hand. Another important thing to note is that we need to be careful when handling patients' bodily fluids. Most chemotherapy drugs are excreted in bodily fluids within 48 hours, so 2 days of administration. So within that time period, 2 days after chemotherapy administration, any time that there's potential for exposure to bodily fluids, you should be wearing a gown and 2 pairs of gloves. Some other general tips to prevent exposure to contaminated bodily fluids is to encourage patients to use toilets rather than urinals and bedpans to reduce handling of those fluids and risk of spill. Another measure is we want to make sure we're protecting the skin of incontinent patients by cleansing the patient really well after they have an episode of incontinence, and then applying a moisture barrier. And then considering decontamination of the environment, so surfaces like a nursing station or an IV pole or an IV pump where that might be contaminated with hazardous drug. Ideally, we would use something called sodium hypochlorite. Another name for this is Jack or bleach. And this ensures that the chemotherapy is deactivated. Alcohol alone will not deactivate the chemotherapy, so we need to be using the sodium hypochlorite, the bleach or the Jack, when we are cleaning environments where there could be chemotherapy contamination. So if you accidentally are exposed to a hazardous drug, what should you do? So if it is just your skin that has been exposed to chemotherapy, you want to remove the PPE that you're wearing and the clothing if it's contaminated, and then immediately wash your skin with soap and water. Again, not just alcohol, make sure you're using soap and water. If there is exposure to the eyes, you would rinse for 15 minutes, either using the eye wash station or the normal saline that we mentioned earlier. If you believe that you may have inhaled a hazardous drug, you would move away from the area, of course, and then refer to, for inhalation, refer to safety data sheets. Hopefully would be available for specific interventions to take in that case of inhalation. And then if you have accidentally ingested hazardous drug, which hopefully will not happen, it's best to not induce vomiting. That might be an intuitive thing to do, but it's best to not induce vomiting unless for that specific agent it is indicated. And then, of course, we would seek for cases of inhalation and ingestion and even eye exposure, we want to be seeking emergency treatment. So after chemotherapy has been mixed and administered, and there is, and we need to dispose of the waste that's produced at those steps, we need to be careful with how we're disposing of all of those, everything that has been exposed to chemotherapy. So this includes vials of chemotherapy, this includes syringes that were used to mix chemotherapy, IV bags that had chemotherapy injected into them, any IV set or IV line that chemotherapy was administered through, any PPE used during mixing or administration. All of those things need to be disposed of safely, because we want to make sure we are not contaminating the local water supply or soil with hazardous drugs. So make sure we are not, that we're never discarding hazardous drug waste into a sink or a toilet or a landfill. And ideally, what would happen with all of this chemotherapy waste is incineration. So we can talk more about this offline or on another planning call. But ideally, an incinerator would be available to just for disposal of hazardous waste. So it's important that patients and their families are made aware of how to protect themselves also from hazardous drugs. So we want to be providing patients with that information. So we want to educate them on how to handle bodily fluids, as we discussed. So some general measures for patients that have received IV chemotherapy. is when they're handling bodily secretions that they're using PPE at home, so gloves and if a gown is available. And then so if there is linen that's soiled with bodily fluids, that be washed separately from non-contaminated linens, and ideally washed 2 times. And then because we know that there's potential for chemotherapy to still be present or chemotherapy metabolites to be present in bodily secretions, we want to educate patients on the importance of avoiding sexual contact for 2 days. And then so that they're not exposing their partner to those bodily fluids. And then with if patients are taking oral chemotherapy at home, you can see on the slide here some general measures that you should be educating your patients on. So making sure that patients are washing their hands before and after handling oral chemotherapy, again, with soap and water. Patients should be wearing gloves while they're handling chemotherapy, oral chemotherapy. You want to, of course, store oral chemotherapy out of reach of children. And then oral chemotherapy should never be crushed or split unless specifically indicated by the provider. All right, so that brings us to the end of our safe handling lecture. So I'll pause here, and if you have any questions, please unmute.
Feel free to also type your questions into the chat if you would like to. Oh, it looks like we have a raised hand.
Yeah, Eva.
Yeah, thank you. This is Julius.
Hand up.
Yeah,
Feel
thank
free
you
to
for the
unmute,
presentation.
Eva.
Yeah, thank you for the presentation. I'm just concerned, like for our setting, most of the patients are on OBD level. So when the patient goes home, because we're looking at after 48 hours, when it comes to the waste, the body fluid. So I'm just concerned what could be some education would give them home, because some family are using one bathroom and this patient has taken chemo and she's going home. What could be some of the health education, because you can't tell them not to use the bathroom with the other people, so and they can't go in the bush. That's my major concern.
Yeah. I think in the case where a patient is not able to use a separate toilet from other family members, that's fine. That's okay. If I would just advise them to do what they can to avoid spilling, avoid any spills. Like if they are just making sure the toilet seat doesn't have any spills on it. If it's a male patient and they are urinating, I would ask them to sit on the toilet rather than standing to prevent any spilling from happening. And then if the toilet seat, if the toilet has a seat that comes down, I know not all of them do, but if the toilet has a seat that comes down, I would tell the patient to close the lid of the toilet before flushing, so that there's no contamination that happens that way when the toilet is flushing. Yeah, so it's okay if they're not able to use a separate toilet. I would just make sure they're doing what within their means what they can to prevent any spilling or contamination from happening. Does that address the question?
Yeah, thank you so much. It's just of concern because our setting is kind of difficult, but yes, we will still encourage them because it is just the education aspect is something that is of concern here or everywhere in low income setting. Because here, how you see one family just receive one bathroom. Yeah. But thank you. Yes, we will still try. Yeah, thank you.
Thanks for the question. And I will say, like, even in settings that I've worked in Canada or the United States, patients are sharing toilets. Not all patients have their own toilets, and so just important to make sure patients are aware of the risks of exposure to themselves and to others, so that they are just doing what they can to reduce any spilling or contamination.
Presley from Liberia. Yeah, my concern has to do with disposal of those wasted materials. Now, from your slide, there are many dumps don't dispose in landfill area, garbage, and so on. And incineration being the ideal method of getting rid of the waste. And looking at our own society here, we don't have incinerator now. So my concern is there any recommendation wherein we can use some antiseptic material or reagents to see how best we can maybe and before disposing the waste in any of our traditional methods of disposing waste?
Yeah, that's a good question. I will say this is not my area of expertise, but I'll reach out to some of our team members and we can brainstorm on what the best approach is for disposing of hazardous waste in your setting. If it's not possible to use an incinerator. I know in other settings where I've worked, there's not an incinerator like at the hospital where chemo is being administered, but in another area of the country, there is an incinerator. I know that travel logistics are not the easiest in Liberia, but if it would be possible to transport waste to a center where there is incineration, that is an alternative, but I imagine that probably would not be easy to do in Liberia. But yeah, let me think more about this and talk to other team members, and we can discuss what approach is best for waste disposal in your setting.
All right, thank you.
Thanks.
All right, are there any other questions?
All right, I think we can move on to the last section of this lecture, which is patient education. This is a shorter topic, so we should wrap up pretty quickly. So the learning objectives of this portion of the lecture are to understand, the importance of patient education in cancer care. Hopefully you will be able to verbalize key teaching points for patients undergoing cancer treatment, and that you will be able to verbalize strategies for effective patient education. So what is patient education? So here's just a detailed definition of patient education. So it can be understood as a planned learning experience using a combination of methods such as teaching, counseling, behavior modification techniques, which ideally influence patients' knowledge and then subsequently their health and illness behavior. Patient education and counseling involve an interactive process that assist patients to participate actively in their care. So it encompasses a lot of different things and is a really important consideration when we are treating patients with cancer. Why is patient education important? So patient education really empowers active participation in autonomous decision making. So we want to be involving patients in their care decisions where possible. And if patients don't understand their disease and what treatment options are available, they will not be able to participate in their care decisions. So so that is one important benefit of patient education, is enabling that participation. Patient education improves health-related quality of life and patient satisfaction. It alleviates stress and anxiety. Any patient that has just received a cancer diagnosis is going to be stressed and going to be experiencing anxiety to some degree. I have never met a patient who is not experiencing any degree of stress or anxiety. And so if they, and the root of a lot of that stress and anxiety is an uncertainty about what is happening to them, about what they can expect in the future. So if we're able to address those uncertainties, then that's just a really good opportunity to alleviate stress and anxiety. Patient education has been shown to improve treatment adherence. Studies have also shown that it decreases the side effects of treatment, and additionally that it decreases healthcare costs. So a really important thing for all of us to be thinking about, whether we're a nurse or a doctor or a pharmacist, anyone on the healthcare team is able to provide this education and contribute to these important outcomes. So what are some information needs of cancer patients? What do you guys think are things that we need to be talking to our patients about and educating our patients on? If anyone's able to either type in the chat an information need that they can think of, or unmute and share an information need, that would be great. All right, if not, I'll just share. I'll share some things that I brainstormed. So this is a list here of components of care that we should be providing education to our patients on. So one, diagnosis. We need to counsel our patients on the disease that they have, or what that means. Treatment goals is also really important. So is the intent of the treatment we're providing to the patient, is it to cure their cancer? Or is it to palliate their cancer and just provide symptom relief and improve quality of life? That's really important for patients to understand. Imaging and lab tests, there can be a lot of uncertainty around that for patients. So when a patient is going for a biopsy, we should be telling them what that means, why they're getting a biopsy, what the procedure will entail, what are potential complications of that procedure, and as well as imaging. So maybe their biopsy came back and confirmed cancer, and now we're sending them for a staging CT or X-ray. We want to tell our patients why we're sending them for those tests, what they can expect when that test occurs. Those are all important things to discuss with our patients. We've talked a lot over the course of this series about treatment side effects, both short-term side effects and long-term side effects. So patients should be counseled on what the potential side effects are of the specific treatment that they're receiving, and then how to manage those side effects and what to do if they do occur. Treatment schedule is also really important to talk to patients about. So if a patient, for example, has locally advanced breast cancer and they're going to be receiving 4 cycles of doxorubicin and cyclophosphamide, and then 4 cycles of paclitaxel, and then surgery after all of that, we want to tell patients about patients need to know what the plan is for that schedule. That's really important. When to seek help also is really important. So we've talked a little bit about some situations that would warrant seeking help. So for example, if a patient has a fever, what are they doing? If they're at home and they have a fever, what should they do? Making sure they understand the importance of seeking help in those situations. If a patient is taking oral medications, we want to tell them how best to take those oral medications, what is the schedule, what time of day they should take it, if there's any other considerations. Family planning as well, I think Bonnie talked a little bit about last week. So making sure female patients understand that they should be on contraception during treatment to prevent pregnancy. So these are the key informational needs of cancer patients. There are plenty of other ones, but these are key components that we should be discussing with all of our patients. And who provides patient education? So it's not one person. It really is a team effort. So patient education can be provided by anyone on the multidisciplinary team. Some members of our team a couple years ago did a systematic review that looked at who is providing patient education in low and middle income countries. So primarily nurses were the ones providing patient education. So 33% of all patient education that was reportedly happening in these studies was done by nurses. But you can see various other team members also involved in patient education. So from doctors to researchers, the pharmacists, and medical students. So all of us can play a part in patient education. How do we make sure we are effectively providing patient education? This is really important as well. There's all kinds of patient-related factors that we want to consider when providing patient education. So what is their literacy level? What are their reading skills if we're providing written materials? What is their preferred language, preferred learning style? What support systems do they have available? So ideally, when patient education is provided, it should happen with family members or someone from their support system there at the same time. So the patient isn't the only one receiving the information. What is their pain level and their anxiety level? If a patient is having 9 out of 10 pain and experiencing a lot of anxiety, that is probably not the moment where you want to be providing patient education. So these are just all things to consider before educating our patients. Here are just some additional practical tips for patient education. Ideally, we would use multiple channels to deliver instructions. So one example of this is explaining the medication side effects verbally, sitting down with the patient and just discussing those side effects, but then also giving a handout that they can take home and refer to from teaching aids, such as pictures or diagrams or demonstrations. Again, involving family members and caregivers is really important. Patient advocates and patient navigators, if they're available, also important to include. And then one model we use to evaluate how a patient has understood the content after providing education is the ask, tell, ask model. So let's say you are describing medication side effects. You might start the teaching session by asking a patient what side effects they are aware of that medication. And then you would tell them what the side effects are, fill in any gaps that they were unaware of. And then after you have explained to them what the side effects are, you would ask them to repeat back to just confirm that they understood what you have explained to them. All right, so that actually brings us to the end of our patient education talk and the end of our lectures for the day. I will again open up the floor for questions either in the chat or if you guys want to unmute. Happy to answer any questions about patient education or any of the other content that we reviewed today. And I know a lot of this information that we reviewed today is really hard to conceptualize until you actually have experience with chemotherapy preparation and administration and safe handling. So as you start to provide chemotherapy to patients, I am happy to take any questions. If I'll share my email as well. I should pull up the side of my email. Yes, so this can be an ongoing conversation. Maybe put it in my chat, in the chat.
Okay, thank you very much. Anyway, on my side, we don't have any question, but if we have anything coming up, we will get to you by email. This is Gerald from Liberia.
Thanks, Jared. Yeah, happy to address any questions as they come up.
All right, so if just one last check, does anybody have any questions? Okay, in that case, we will be meeting again next week at the same time, 2 p.m. for our final lecture or our final day in the lecture series. So we will be reviewing first surgical intervention for breast cancer, and second, we will be reviewing palliative care. And then we will end that day with a post-test. So you will be taking the test that you took in the beginning of this lecture series again, and then we will also be doing a course evaluation just to see how this went and any ways that we could improve. So we really ask that you come to this last session. I promise you it will be great. If you have any questions in between, please feel free to send me an email. If you have questions about anything we learned today, feel free to send Alyson an email. Her email is in the chat. Does anybody have any questions about the logistics of the next week? No? In that case, we should be all set. Have a great evening, everyone, and a good weekend.
Thanks, everyone.
All right, I'll stay on for a few minutes in case there's any other questions, but feel free to head out, everyone.
Yeah, I will too.
No question, no question. Okay, thank you so much. No